All right. Hello, everyone, and welcome to the 15th session of the EJCN Journal Club. My name is Michelle Sherman. I'm with the University of Minnesota here in Minneapolis, Minnesota, and I'm going to be the moderator of the meeting. Today, I am pleased to be joined by Stephanie Hooker, Department of Family Medicine and Community Health at the University of Minnesota here in the United States of America. Stephanie Hooker is the lead author of the article we're going to be discussing today, Mutuality and Heart Failure Self-Care in Patients and Their Informal Caregivers. This was published in the February 2018 issue of the European Journal of Cardiovascular Nursing. To kick off, Stephanie, I'd like to begin with asking you to please give a short introduction to your paper, please.
Yes, I will. Thanks, Michelle. So I'm really excited to share about this paper. This is a project that I have been working on for a number of years, and so it's great to see it finally in print. We are interested in how caregivers affect patient outcomes and vice versa, how patients affect caregivers. In this study in particular, we were interested in how the relationship between a patient and their caregiver can affect their outcomes. So we first got interested in this study because we were noticing clinically with patients with heart failure that when they had caregivers who seemed supportive or who were around, they tended to be doing better than patients who either didn't have a caregiver or didn't have a very good relationship with the person they identified as their caregiver. And so we started to dig into the literature, and we found that there are a lot of studies that look at how patient individual factors affect their self-care. And we think of self-care of heart failure, we think of doing a lot of the things that are recommended to make sure that people stay out of the hospital. So that includes things like trying to eat a low-salt diet, watching their fluid intake, making sure they get some exercise, and overall just kind of managing their health. The problem was that we were seeing patient level factors were influencing self-care. And then there were some studies that showed that caregiver level factors influence self-care, but there weren't very many studies that looked at how patients and caregivers together influenced patient self-care. And that's why we were interested in doing this study. So we specifically looked at mutuality. And mutuality is just a term for a part of the relationship. It's about how much the caregiver and the patient express love and affection for each other. They engage in shared pleasurable activities, and they overall just seem to be kind of working well together. And so we really think of mutuality as just kind of another aspect of the quality of the relationship between two people. And so in our study, we recruited, well, it was part of a bigger trial. So we had about 300 patients who were participating in a study of looking at how a intervention that was designed to be like a collaborative care intervention with both patients and caregivers could be involved, but they were mostly getting medical care from a collaborative care team and as talking to a social worker via telephone. We just looked at the baseline level of this trial and found about 99 caregivers who were willing to participate. So about a third of the patients had caregivers that could participate in this study. And so we asked patients and caregivers to complete self-report measures of mutuality, so that aspect of their relationship quality, as well as self-care. So patients reported on their own self-care of their heart failure, and caregivers reported on how much they helped the patients with the self-care of their heart failure. With self-care, we looked at confidence. So how confident were people in their ability to care for themselves, as well as we looked at what they're actually doing. So that's the self-care maintenance, how much they reported actually engaging in those behaviors. And overall, we found that mutuality was related to patient confidence in engaging in self-care, as well as caregiver mutuality was related to caregiver confidence in helping with their patient self-care. And so mutuality seemed to be an overall positive predictor of confidence. The interesting part was we didn't see any what we call actor effects, partner effects, meaning that across the two people, that however a patient perceived the mutuality in the relationship didn't necessarily affect the caregiver confidence in self-care, and vice versa. How a caregiver perceived their relationship didn't affect the patient confidence in their self-care. The other variable that we looked at in the study was burden. So how much did the caregivers feel stressed or overwhelmed by having to provide care for these patients? And we found that there was a strong negative association between caregiver mutuality and caregiver burden, meaning that the more patients felt that the relationship was a good relationship, or sorry, more caregivers felt the relationship was a good relationship, the less burden they were in providing care for that person. And we know that caregiver burden is related to a host of negative outcomes for caregivers. So it was good to see that when they felt the relationship was strong, that they were feeling a little bit better. Overall in our discussion of the study, we thought that this mutuality provides kind of a basis of confidence for patients and caregivers to engage in self-care, helps them get through the stress of having to deal with a chronic illness, and ultimately having someone that is in your corner, so to speak, can be helpful for patients to feel motivated to take care of themselves. And that is kind of what we found in the study.
Great. Well, thank you. Really interesting study.
Yeah.
I appreciate that. And you collaborated with a number of folks in a number of settings, it appears, huh?
Yeah, I had a great team working with me. Dr. Sarah Schmiege is a professor of biostatistics at the University of Colorado. Dr. Ronak Trivedi is at, I believe she's at the VA in Palo Alto. Mm-hmm. And Dr. Amoyle is also in the University of Colorado. And Dr. Beckelman is the lead of the project overall. So his trial was the one that we conducted the study at, and he's at the University of Colorado and at the VA in Denver in the USA.
Great. Okay. So, Stephanie, there were a number of questions that were submitted. So if it's okay, we'll kind of start off with those from different folks, which is great to have some input, and then a couple questions I thought about, and we'll just have a little discussion. Does that sound okay?
Sounds good to me.
All right, great. So a couple introductory questions is one, if you could please explain kind of in simple terms what a dyad is. That term is used in the paper, and could you help us understand what that means, please?
Sure. So a dyad is just kind of a fancy word for two people.
Okay.
So we think of a dyad as a patient and a caregiver. It could be a couple, like a husband and a wife, or two partners. It could be a parent and a child. So we just think of that as just two people that we're looking at together in the study.
Okay. Okay, great. You kind of mentioned this one earlier in terms of wanting to look at the relationship that most of the research has been done on individual patients. But what in particular drew you to think about the construct of mutuality, and why is that important?
Yeah, so, as I mentioned earlier, mutuality, it was just kind of one variable that we thought would be really interesting to look at how to specify the quality of the relationship. And really, when we think of what mutuality is, the mutuality measure that we use asks about how much do you find affection for this person, or how much do you enjoy spending time with them outside of, just, being a caregiver for this person, really.
Okay.
It's how much do you really find this person a meaningful person in your life, really.
Okay.
And that's why we were interested in that, because it's above and beyond just the fact that they're, qualifying somebody as a spouse or a parent or a child. It's about how much is this relationship working for you.
Okay. And that's something I think that is interesting and good to note, is that when we talk about these dyads, that they weren't all spouses.
No.
Some of them were, but a good percentage of them were other relationships as well.
You're right. Yeah. So we had about 60% of our study were actual spouses, and an additional 10% identify themselves as partners or significant others. Okay. But then a quarter of the people that we had in the study were actually children of the patients. And so we didn't limit it to spouses in the study because we recognized, especially in our group, that it wasn't always the spouse, or the patient may not have had a spouse that was helping people with their relationship. And we didn't want to exclude patients who didn't have a spouse or partner helping them.
Okay. And if I recall correctly, you did compare to see if there were really any differences between those sorts of caregiver relationships, and there weren't.
No, we didn't see any differences in terms of mutuality between spouses and others. A couple of people just had friends or neighbors, like people that were helping them. So that was the interesting part, is we know that there is just really, at least in our sample, no difference between the two.
Yeah, okay. Another submitted question was that an observation that almost all research in caregivers is in heterosexual couples, and wondering if you could reflect on why that is, and if and how and maybe should we change that?
Yeah, I have definitely noticed that as well. And I think one of the reasons that we have seen this kind of trend is because of the way people measure relationship quality. Some of the measures of relationship quality have been specific to married couples. And so like the dyadic adjustment scale has been a scale that has been used for married couples. And so I think just for simplicity, a lot of people who have studied this have just limited to spouses. I think that obviously that leaves a lot of people out, including, potentially homosexual couples or other people who aren't legally married. It leaves out the patients with their children as their caregivers. Yeah. And I think that is doing kind of a disservice to our literature to really understand what's going on with patients who don't have a spouse that they identify as their primary caregiver. So I think it would be great to expand who we're including as caregivers, how we identify them. In our study, we asked the patient, who is the person that helps you most with your illness, just besides your healthcare provider? And I think that question is a good way to kind of identify that person.
That's nice. It's not limiting.
Right.
And so sounds like you believe it's important to continue to look at the different kinds of dyads.
Yeah, absolutely.
Yeah. Okay, good. Some other questions were submitted. One was regarding methods. And this person noted that about 45% of the patients had caregivers that participated, which is quite a good number. And she really was referring to the difference in the number that were recruited for those that the caregivers with them at the hospital visit versus those who did not. And she was wondering if you could please speculate on what would have happened in the study had they put more emphasis on trying to include caregivers who were actually not there at the visit, and kind of any reflections you might have on that.
Right. Yeah, I think that was a really good observation by the person that submitted this. And it was a concern of our study team that we were having a lot of trouble getting caregivers who weren't at the visit. So just kind of to give some numbers for folks, in our study, we had only about 33%, or about a third of the patients who identified that they had caregivers, their caregivers were at visits with them. And we had a majority of those folks who were there willing to participate. It was over, it was 84% of those people.
Yeah,
so yeah, which was great. So they were willing to engage and participate. So despite that, because there was only a third of people at the visits, we had to reach out afterward to 2/3 of those caregivers. So we tried by phone, by mail, kind of any way, or email, any way that the caregiver or the patient said that we could contact that person. Unfortunately, we only had about a quarter of those folks participate in the study. So we're not really sure what is going on with that. Obviously, it's probably easier to participate in a study if you're there and you're already involved. But one speculation could be that the relationship between those folks who come to the visits with the patients versus those who aren't there maybe is better. And we don't know, unfortunately, because we can't study that. Ultimately, there could be a lot of reasons why caregivers who weren't there couldn't participate. We know that, at least in our sample, that there was a good proportion of caregivers who were working as well as providing care a lot of the time. And that's probably one of the reasons why we didn't get those people, or they have other responsibilities. It's hard to participate in research if you don't have time.
Caregiving is tough and takes a lot of time and energy.
Absolutely.
So one more thing.
Absolutely. Yeah. So, we don't really know how our study results would have changed if we would have reached a lot more of those people who weren't there. I think that, we could speculate that the variability in mutuality could have been wider if we had folks who weren't at visits, but we don't really know the answer to that. So I think in future research, we would love to try to catch those people a lot more. I think there will always be the challenge of trying to get people to participate in research who aren't just right in front of you in that moment.
Yeah, exactly. Okay, good. Another question, kind of trying to look at reaching out to a variety of people and understanding their different experiences. You had in one of your tables and talked about different classes of level of impairment of the patients living with heart failure, and just kind of speculating and thinking about the experiences of caregiving and relationships and mutuality among these folks. Any thoughts or reflections on if the caregivers who have to do a lot more, either in terms of time of caregiving for the patient or more ADL sorts of activities of daily living, do you have any thoughts or ideas about the relationships between amount of caregiving and mutuality or relationship factors? Anything that you know of or thoughts about that?
Right. So I believe what you're referring to is kind of the NYHA class, kind of the way we specify, how severe someone whose heart failure is. And so we know, people who are in lower classes, such as class 1 or 2, are not as burdened by usually shortness of breath is kind of how they identify that that's causing a problem. Whereas folks who are at higher levels of NYHA class, such as 3 or 4, they're short of breath from very limited activity or even just at rest. And so I would suspect those people tend to need a lot more help from somebody else. And that can be an extra burden on that caregiver, obviously, to have someone who is more affected by their chronic illness to kind of need some more help. We didn't look specifically at NYHA class and how that was related to mutuality, but I will say, kind of a behind the scenes look is that we also had a measure of what we call objective burden. So objective burden is this idea of what are you actually doing for this person. So we kind of wanted to know if there was an association between objective burden and mutuality. And we actually didn't find a strong relationship there. Okay. It was not significant. And there was actually, the relationship between objective burden and perceived burden, which was the measure that actually was in the study, was very, very low correlation. So that suggests that some people, perceive that they're much more burdened by even doing very small tasks for someone versus the opposite of, people who are doing a lot for a caregiver might perceive that they're not doing very much or it's not burdening them. And that could come back to that relationship too. Thinking that, if this is a person I love, that I really care for, I don't care if I'm doing a ton of things for this person because that is my job or that's my role in helping this person in our lives at this point. Whereas other people maybe feel a lot more burdened and that can affect their relationship for sure. So I think it is a good thought for sure that we're thinking about what are people actually doing, but we don't know.
And I think about, for many people, the experience of caregiving gives them a lot of meaning in their life. This is really what I'm here for. I love this person. We've been together. Your caregivers have been together an average, 37 years?
Yeah, a long time.
Relationships.
Right.
And so this is really a person I've shared my life with and will always share my life with. And so it gives me a lot of meaning and joy to express my love in this way.
Right. There is another scale that's kind of the opposite of burden, which is the benefits of caregiving. So people who do feel that caregiving gives them some benefit in their life. Yeah. I think there is, like you said, meaning, which is another interest of mine. How do we get or derive meaning from our lives? And a lot of people derive meaning from the relationships they have. And obviously in the context of a chronic illness, that relationship and that meaning about what you're doing for that person can become really salient.
Yeah. And I've just been kind of speculating about if there's the longitudinal research looking at this, what we know about how mutuality or burden or things like that changes over time. Because again, the average number, although you had a pretty big range, if I recall, in terms of number of years of caregiving or of health, how this might change over time would be interesting to look at, I think, in the future as well.
Yes, absolutely. Our overall study was a year long, so we did have some repeated measures. I think we also had some issues retaining caregivers over time, so I'm not sure exactly what we would find, but I know right now there's no long-term studies of this. Okay. We don't know how relationships change over time, or even, obviously, as most people probably listening know, that heart failure is a progressive illness, and we know that it's characterized by these dips where people get worse. They may feel a little better over time, but overall it is life-limiting and progressive. So it is a problem that you see, as people get closer to the end of life, how that affects the caregiver maybe changes. Yeah,
and I think about the literature showing both for the patients and for the caregivers the comorbid depression that can affect each person individually and in their relationship, and the kind of implications that may have for intervention at an individual or dyadic level.
Yeah, Dr. Trivedi's model includes depression as a predictor of kind of how this impacts caregivers and patients together. Obviously, there is a high, like you said, high comorbidity within patients who have heart failure who also have some depression. But I think it's not uncommon for caregivers as well to kind of feel like maybe their life is being consumed by their caregiving responsibilities, or they're not able to have the same kind of relationship with the patient as they did before the illness. So we definitely need to continue exploring how this works.
And maybe anticipatory grief. This person is not the person that I fell in love with or spent all these years with, and it's painful and sad to see their health declining.
Yeah, absolutely.
One of the kind of questions I would have in terms of thinking about different sorts of ways of helping these couples is, there's certainly lots of different approaches for helping couples. We think about, traditional couples therapy. We think about, relationship prevention or strengthening sorts of things. There are self-help books, all sorts of stuff. Any thoughts or reflections on how interventions to strengthen this concept of mutuality might be helpful or important for these couples?
I think that I know you come from a traditional couples therapy background. There's a lot of things that we could do. And, I come from a psychology background too. So I think of affecting a relationship is something that we know how to do in psychology. And so I think, there are some interventions that have been studied that look at specifically how to affect the relationship for folks with chronic illnesses, and we could definitely learn from those. But some of the simple things that even, some healthcare providers like nurses or doctors could do would be to encourage both a patient and a caregiver to identify things that they find or appreciate about the other person in their life. Obviously, we have one aspect of that would be, just saying like, thank you for doing all you do for me. And, a lot of the times I think it's hard for people to verbally express that appreciation, but encouraging patients and caregivers to express appreciation, but also to work on communication, to be able to say the things that are bothering them and to do it in a way which helps them move forward. Obviously, that can range from a very simple, one-time intervention to kind of more of a couples therapy model where maybe they need to see somebody to work on some of these issues. But I think that there are definitely opportunities for us to explore how to address this, and specifically within the context of having a chronic illness, because a chronic illness is another layer of complexity upon this relationship, and it affects not just the patient, but it affects the caregiver too.
Yeah, for sure. And just think about at a broader public health perspective. We look at lots of patients in cardiology offices and things like that, and who do we identify or who do we target, and then subsequently how do we reach out to them and support them? Again, maybe in your study, about a third of them actually are in the office. So that, and then even at a broader level, where, with limited resources, of course, where do we focus our energies and resources, and what couples or patients?
Yeah, I would say that research has shown targeting folks who are obviously identifying problems would be like the first start. You get kind of is more bang for your buck, so to say, as going for people who identify that they're either feeling like the relationship is not very good, that maybe caregivers are more burdened, patients are more depressed, people who perceive that they have low social support in general. Those are the folks that I think probably need to be targeted. And obviously that's, it can be hard to figure out who those people are. Right. And I think, I encourage healthcare providers to have kind of an ongoing relationship with their patients, and to open up those questions. Like, how do you feel like it's going with your caregiver? How is it going in terms of your relationship with that person, but not, but also like, do you feel like this is a supportive person in your life? And encouraging the healthcare providers to also address this with caregivers. Asking patients to bring a family member, whoever that person is, into the room with them is a great way to kind of just open that conversation. It also gives you some behavioral observations. You can kind of see what's going on between these two people when they're in the room with you together. And so that's the key part, is just to open it up and just let those people tell you what's going on.
Which, seeing it may be more accurate than what they actually tell you.
Yes, that's probably true too.
Some interesting things.
Yes.
Yeah, I just also think about, part of what it's interesting to me about your study is this concept of mutuality. And I think, regardless of the health condition, be it a mental illness, be it heart failure, whatever else, it can often get kind of in the role of, this is the patient, this is the caregiver. And for an intimate relationship, I'm often thinking about more of a mutual and how can we support one another. So as I reflect upon caregiving and think about relationship dynamics, I really also think about nurses, doctors, whomever else, empowering the patient to also be attentive to his or her support person, whoever that is, such that it is more mutual, supporting one another rather than just unidirectional sort of provision of support.
Yeah, I think, with the illness there, it just becomes the relationship. You consume the relationship, and all the focus comes on one person. And I, like most of these folks, probably had relationships with these people before the illness came around. And so the dynamics of the relationships really shift when there is this focus on the one person. And so we definitely want to make sure that we're able to identify how a patient can continue to support the caregiver. Obviously, there was some bi-directional relationship things happening prior to this illness. We hope so. But to continue to do, express appreciation, to express love, to continue to have shared activities together, and maybe, making their life bigger than just the illness. Yeah.
You used a really nice kind of narrative therapy sort of idea of externalizing illness. It's not that you're sick or I'm the caregiver, but we're together working on this, which I think is kind of a nice metaphor.
Yeah.
Nice idea of thinking about it.
Yeah, there is another construct in the literature. I might be not get the term exactly right, but it's something about collaborative communication, essentially. This idea that we see this as our problem versus the patient's problem only. Exactly. And so I think that type of viewing of the relationship can be strong for the folks to work together.
It kind of leads me into thinking about kind of what now in terms of research. You mentioned a couple things in your paper. One in terms of thinking about maybe bi-directional caregiving, given that both members may be struggling. Any comments on that, and any other thoughts of where this research is heading, or where you think next steps are would be the literature?
Yeah, I think with our aging population, this is going to be a problem. We know that a lot of caregivers have their own health issues, and so I think it's going to be a bi-directional issue where we're not going to be able just to identify one person as the patient and one person as the caregiver. And so I think we don't really know how to do this yet, but we're going to have to figure out, like, what are you doing for this person and what are you doing for the other person, and how is that affecting your relationship overall? I have no idea what to expect, but I think it's something that we're going to have to figure out in the coming years.
Yeah, because couples research to begin with is tricky. Looking at each person's experience, each person's perception, but then we add in who is the caregiver, and are we defining it based on time you spent doing it, amount of limitations, what sort of ADLs do you do? There's a lot to kind of figure out.
And I think the way we identify who's the patient is by the illness right now, right? Not by how impaired this person is.
Which can vary a lot, right? I mean, that this NYSA rating or NYHA, or whatever else, there are lots of different variables we can use, but at the end of the day, and fluctuate too, right? I mean, if you're looking at a mental illness or other health problems, it's not necessarily a linear progression either. So it's tricky.
It is very tricky. I think we're going to have a lot of challenges in our research to figure out how to study this in the future.
Well, I know, Dr. Hooker, our time is almost up. Were there other things that you were kind of wanting to mention or share or reflect on today about your work?
I just would love to say that I'm excited for this opportunity to talk about this. I think this is a really important issue in healthcare, that we're going to have family members involved in a lot of different aspects of patient care. And so being able to think about the person beyond the illness is what I hope that, a lot of healthcare providers can get from this, is that, we have patients that come into our office and primarily talking about, their health problems, but they have lives outside of this, and encouraging healthcare providers to think about the person in context, in the context of having a family member who might be a caregiver, in the context of having a life that they had prior to this illness, and how that's affecting them as a whole. And I think that's really important for us to think about all together.
The biopsychosocial model, right? There's
Absolutely.
so many different factors that are influencing that. Well, this is really important work, and you have so many strengths of the study, just in terms of multiple sites and a large sample size, both perspectives. So congratulations.
Thank you.
Really important work, and I also enjoyed the opportunity to think about it and talk about it with you today. So
yes,
thank you.
And thanks to everyone who watched today, and hopefully you all learned something and got something out of this today.
So thank you very much.
Thank you.